Good morning. So I think some of my results have already been discussed, but let me go through the study again. So this is the keynote 522, and these are the results of the overall survival analysis from this study. So we are all familiar with the study. We know that the first interim analysis showed an improvement in PAT-CR rates with the addition of pembro to chemotherapy. Delta was 13.6%. The fourth interim analysis at a median follow-up of about 39 months showed that there was actually a statistically significant improvement in EFS delta of about 9%, and which actually propelled the combination to regulatory approval usage in day-to-day real practice. And this presentation in ESMO last year was at a median follow-up of 75.1 month, and they wanted to look at the OS analysis. So this is the trial schema. I'll probably want to highlight two things here. A, they did not allow dose-dense chemotherapy. B, there was no capecitabine or olaparib for those patients who did not achieve a PAT-CR. When they designed the study, the two studies had not been read out, the CREATE-X and the Olympia. And OS was a secondary endpoint. The primary endpoint was PAT-CR and EFS. So what were the results? So these are the updated event-free survival. And so clearly there's a very clear, nice separation of the two curves at 5-year follow-up. Event-free survival for the chemo alone arm, 72.2%, improving to 81.2% for the pembro plus chemotherapy arm. So durable benefits. OS, very interesting. Chemo alone arm, 5-year OS rates of about 81.7%. Improving to 86.6%. This is statistically significant improvement, a hazard ratio of 0.66. I think this is, when you look at different subgroups, the benefit seems consistent. A deeper look, slightly older people, wide confidence intervals, T3, T4, interestingly, wide confidence intervals. The authors themselves said that we need to be cautious when we look at these subgroups. And this is the OS according to PAT-CR, and this is the interesting part. So for those patients who do achieve a PAT-CR, the 5-year OS rate for chemo alone arm is 94.4%, while pembro plus chemo is 95.1%. So a delta of about 0.7%. And you look at those patients who fail to achieve a PAT-CR, 65.7% 5-year OS. So 1/3 of these patients have recurred and died because of that recurrence, improving to 71.8% for pembro OS. So a delta of about 6.1%. So the authors concluded that the addition of pembro to chemo in the neoadjuvant phase and as maintenance in the adjuvant phase led to a clinically meaningful, statistically significant improvement in OS. This OS benefit was consistent across subgroups, including those defined by PDL1, nodal status, tumor size, and was observed regardless of PAT-CR. The EFS benefit continues to be significant, clinically meaningful, and there were no new toxicity concerns. So what I might is, I think clearly the trial is positive. We've seen benefit in PAT-CR, EFS, OS. The EFS improvement seems durable. I think we have, at 5 years, when you have a 9% improvement, you do know that 90% of patients of TNBC would have recurred by now. What's interesting is, for those patients who do achieve a PAT-CR, is it compulsory to continue pembrolizumab? I think in most of our clinical practices before the PAP, I was stopping pembrolizumab in the maintenance phase. I think this data probably provides a little bit more confidence in doing that. What was the reason of improvement in the survival in those patients who failed to achieve a PAT-CR? One, possibly biological effect. Change in tumor biology in those patients who received pembrolizumab with the neoadjuvant chemotherapy. Perhaps lower residual disease in the pembro chemo arm compared to the chemo arm. Perhaps exposure to pembrolizumab in the adjuvant phase. I think that point is questionable. Clearly, there was a lack of capecitabine as for these patients who did not achieve a PAT-CR. And in the previous study that one of the previous speakers did allude to, the atezolizumab study, those patients could have received capecitabine. The other thing is that these patients did not receive dose-dense chemotherapy. Now, still no predictive molecular biomarkers. There was a separate readout of different molecular biomarkers, inflammatory T-cell gene expression profiling, tumor mutational burden. We couldn't pick up a biomarker which could predict benefit to pembrolizumab. We all question the benefit, the relative benefit of adjuvant phase, and we've looked at some of the retrospective data to say that the benefit may not be there. So these are some of the thought-provoking questions that we have to face and probably we have to answer, but the study was positive. This is the other interesting study. This is Promenade, which is pembrolizumab for early ER-low, HER2/neu negative breast cancer. This is a real-world French cohort study. So the ESMO and ASCO-CAP guidelines recommend a cutoff of 1% for definition of ER. So if any patient who has a ER expression of less than 1%, that is the definition of TNBC. Interestingly, in France and some of the other countries, they actually use a cutoff of 10%. So this ER expression between 1 and 9%, the ER low expression, seems to be a rare subtype. It's about 3 to 6% of all ER/PR positive tumors. What we've known from retrospective studies is that biologically these ER low may be different compared to the ER high or ER 10% or more. They are likely to present with larger primaries. They are more likely to have grade 3 tumors. On a molecular level, they may have more basal subtype, more HER2 enriched subtype compared to the ER 10% or more. And their data, retrospective data does suggest that the DFS and the OS outcomes for the ER low are actually more similar to triple negative compared to those which are ER 10% or more. Although there is also data to say that if you do omit hormone therapy in this subtype, there's going to be worse outcomes. So the author and the group have been using triple negative breast cancer protocols, pembro chemo in the neoadjuvant phase. They were concerned by the lack of data regarding benefit, and this is what prompted this analysis. So they referenced Keynote 522 and Keynote 756. 522, we've seen the results, improvement in PAT-CRs with addition of pembro. Also in Keynote 756, the grade 3 ER/PR positive patients who actually improved in terms of PAT-CR rates with the addition of pembrolizumab. Interestingly, look at the full text of this study. We also saw that for those patients who had ER low, PAT-CR rates were higher. So about 25% PAT-CR rates for chemo alone and 50% PAT-CR rates for pembro and chemo. And when you look at RCB 0 and 1, again, the combined number is much higher for ER low compared to the ER positive population. So the delta of benefit with the addition of pembrolizumab seemed greater in the ER low compared to the ER 10% or more. So this was a retrospective real-life study, 12 comprehensive cancer centers, including all patients receiving the Keynote 522 regimen. Patients had to have ER low, so ER and a PR of 1 to 9% had to be HER2 negative, and the primary objective was PAT-CR. So what were the results? I mean, these are the patient characteristics. So when you look at patient characteristics, a reasonably young population, median age of 49, 89% patients had a tumor which was more than 2 centimeter, about 50% patients had node positive disease, a high number of patients had grade 3 disease as well. About 75% of these patients were able to complete all planned neoadjuvant chemotherapy. So these were the results. PAT-CR, 75% PAT-CR rates in this population, 114 patients. And when you look at those patients achieving a RCB 0 and RCB 1, about 83% patients having an RCB 0 and RCB 1. And this clearly looks similar, if not better, to the results from the randomized trials, the Keynote 522 and Keynote 756. Again, we shouldn't be directly comparing, but this is how the figures stand. So the authors concluded that they did achieve a high PAT-CR rate with the Keynote 522 regimen, that the ER low respond differently to the ER positive patients and more like triple negative breast cancer patients. And the Keynote 522 regimen seems to be useful for this population. My take, again, it's a retrospective study. Numbers are small. We did achieve high PAT-CRs. We do not have long-term data, how these patients perform. I think the key question that we keep on asking and that we've been looking at is, what is the impact of achieving a PAT-CR in a population like this? Does it really impact EFS? I think we'll have to look at the data, the EFS curves of Keynote 756, particularly for the ER low population as well. But we often in our clinic, at least I often in my clinic, discuss the option of adding pembrolizumab to this population of ER low. And while we do lack a randomized phase 3 trial, I think the retrospective data does provide some evidence of benefit. Thank you very much.